Welcome to Tip 42, Treatment of Persons with Co-Occurring Disorders, brought to you by allceus.com. Co-occurring disorders are the rule, not the exception. Whenever you work in a treatment facility, you will find that most people coming in have either a temporary or permanent mental health disorder that they're dealing with in addition to their substance abuse. Integrated biopsychosocial treatment of people with co-occurring disorders is imperative. What does that mean? That means you can't just treat the addiction and assume the depression will remit. Likewise, you can't treat the depression and assume that the person will just quit drinking. It doesn't work that way. We need to look at the person as a whole, their mental health issues, their substance abuse issues, as well as what's causing all of this. There's biopsychosocial stuff. Do they have physical pain? Do they have family relationship problems? Are they having financial problems? Do they live with people who drink or abuse drugs? What are the precipitants? What are the triggers that are going on that need to be addressed? Taking a person, no matter how determined they are, and putting them in treatment and giving them all these wonderful tools, and then sending them back in a sick environment, or sending them back to the very same stressors without addressing them, doesn't help them at all. It's important to realize that even substance abuse mental health issues may need intervention in early recovery. What I mean by that is, a lot of people, when I was working in community mental health, would come in, they'd go through detox, they'd come over to residential, and they'd present with both substance abuse and mental health issues, depression, anxiety. For some people, that was a side effect of the withdrawal from the substances they were abusing, no doubt. For some people, it was a side effect, if you will, as a consequence of the things that they did when they were using. They started to sober up and it was like, oh crap. And they had to recognize and reconcile. But it wasn't a biological or an ongoing major depressive disorder. Nevertheless, for these people to be able to focus and function and progress through treatment in what little time we had available, a lot of times the docs would prescribe a short-term course of medications, whether it be Boost Bar or SSRIs or something that wasn't addictive, wasn't habit-forming, but it was enough to help them focus and kind of break out of that fog. Now, when you're working with people with co-occurring disorders, they're going to enter the system, as it were, at many different places. They may come in through food stamps, they may come in through child protective services, through the criminal justice system, through the homeless shelter, through mental health, through substance abuse. There's any myriad of ways people can get referred into treatment or services. The goal is for every service provider in the community to be able to effectively screen people for mental health and substance abuse disorders. That way the referral can be provided to the person at whatever point in which they enter. I'll make the point here that a referral is not enough. You can't just give person A the name and phone number of the mental health treatment provider that's down the street. 95% of the time, they're not going to follow through. That's probably too much for them to cope with, too much for them to deal with, to actually call and make an appointment and do all that kind of stuff on their own. They're overwhelmed as it is, most likely. So while they're in your office, it's prudent to help them make a call. You don't need to make it for them. It's actually best if they make the call on their own. But if you can do your primary screening and then maybe move them to a triage room or whatever you want to call it, where there's a staff person who can assist them with making these calls, your treatment compliance, your level of follow-through is going to be much higher. And this ensures the efficiency of the no wrong door policy. Once they do get to the assessment piece for mental health and or substance abuse, it's important with everybody, but especially with people with co-occurring disorders, that we use the strength-based approach. Many times people with co-occurring disorders have already been to mental health treatment or substance treatment or one of these single source treatment providers, and it hasn't worked out. That's why they're back in the system. So we need to help encourage them, focus on their strengths. What did they learn from those prior experiences? What do they know from their mom's experience in mental health treatment or their dad's experience in substance abuse treatment or whatever? What are their strengths? What tools do they currently have, and how have they survived until now? You need to do a mental health assessment. What's their current mental health status? And then ask them about, if they can remember, what was their mental health status before they started using? Were they depressed? Were they anxious? Do they have a history of mental health issues? And then, have they been in treatment before? And if they have, what's worked and what hasn't? It's silly to go through and try to force them to do something that they've already done before that hasn't worked. Now, you may talk about why it didn't work and see if there's a way you can tweak it if you feel that it's vitally important that the person engages in whatever activity it is. Oftentimes it's 12-step meetings. That's a possibility. But you also want to focus on what has worked and look at the commonalities in what has worked for that person. Do they do well in group therapy? Do they do well in self-help groups? Do they tend to do better when their time is pretty booked and they don't have a lot of downtime? This is going to be true for a lot of our clients. What sorts of triggers, what sorts of precipitating events occur in this person's life that cause an increase in depression, anxiety, mental health symptoms in general? What do they do when those symptoms increase to cope with it? If they hadn't coped, they wouldn't be here. Now, it may not have been the best way of coping, but what did they do to get through it? And can you build upon that? The next step is substance abuse. And again, it's the same basic principle. What are they using currently? What did they use in the past? Why did they change? Did they develop a tolerance? Did they develop a different need to use? Did they start hanging with different friends? What? And then look again at previous interventions and outcomes. What worked? What didn't? When you went through treatment the last time, I'm sure you developed a relapse prevention plan. So what was it that was lacking that we need to address now so next time you walk out these doors, you catch your relapse before it happens? These are all things that you can build on in the initial interview. Yes, the person has to acknowledge some failures, but they can also acknowledge what has worked, their successes, how long they stayed sober, etc. Play up on those. Most times people coming into the system or back into the system have had their self-esteem take a beating. So it's up to us to help empower them to do the next right thing. Then you want to look at family history. Family history of mental health issues, substance abuse issues, domestic violence, child abuse. We know a lot of things are intergenerationally transmitted. Even if the person doesn't admit to a history of abuse now, it may come up later in treatment. So it's good to identify these issues, ask about them. If the person denies them, that's fine. You don't need to go into a dissertation about how it's usually transmitted in families and it would be highly unlikely that they weren't abused. That'll put them on the defensive. So just accept it at face value unless you feel that the person is in imminent danger, and then of course you need to pursue it further. Then take some general background information. What are their cultures? And most people have various cultures and cultural values and beliefs. They have their family of origin. They have their ethnicity. They have their religion or lack of religion. They have any number of different groups that they feel connected to. What are those groups and what do they mean to this person? You need to recognize the implications for creating a treatment environment and a treatment plan that is in harmony with their cultural values. If they believe in interdependence, don't tell them to go the independent way. If they are more independent, don't force them, likewise, to really rely on their family and make amends when they're not ready. Yes, they have to have social support, but we can be relatively flexible in how we define some of that. Again, ask about their trauma history. If you already asked about it earlier, don't go there again. But you can ask at some point about their trauma history, whether it be rape, assault, child abuse, whether they've committed any of these. It's also good to know. Housing. Do they have safe, clean, stable housing? And all of those are pretty broad. If they're living in an environment where people sell crack door to door, probably not a good environment. If they're living in a house in which they don't feel safe, probably not a good environment. If they're living in an environment where everybody else in the house uses, probably not a good environment. Can you immediately do something about that? No. Most of the time the answer to that is no. But you can help the person identify steps to take to start dealing with it. The first step may be residential treatment. Obviously, if they score out to be appropriate for residential. That will give them a little bit of time to try to figure out what the next right step is. Health. Chronic pain is going to be a chronic pain. You need to help the person learn how to deal with it in a way that doesn't overemphasize medication. There are a lot of issues that people with substance abuse disorders have. Hepatitis being one of the primary ones. HIV. Some of these are more painful than others. And they may need to deal with lots of other pain issues from accidents or whatever. They may have other health-related issues. High blood pressure and diabetes were very common in the treatment facility that I worked at. Helping them learn how that may interact with their substance abuse, how that may exacerbate their mental health issues, all those things are important to do in the early assessment. Help them understand how everything interweaves with everything else and impacts everything else. Financially. Now this isn't financial to figure out whether they can afford your services. This is financial to figure out where their stressors are. Are they in the midst of foreclosure? Do they have a stable job? Do they have money coming in? Are they having any kind of other problems? Do they have debt collectors calling them all the time? All of these can be stressors that will underscore or encourage them maybe to engage in gambling, drug sale, prostitution, other things that might bring them money, say, faster than working at Walmart or Target or Burger King or wherever they may be working. Legal kind of ties in with financial. If they've got certain legal problems going on, you need to assess for that. Are they getting ready to go to jail? Are they just out of jail? What's their criminal history? That'll also give you some insight into some of their other issues, such as anger management. And social support. Do they have any? If they do, is it clean and sober? If they don't have clean, sober social support, are they willing to create some relationships that are clean and sober? And then finally, you need to write up an integrated summary. This used to be one of my biggest bones of contention with my staff. And it required some training because an integrated summary is not just a regurgitation of all the information you just took. The integrated part means you need to talk about how these things interact. How does the mental health issue influence the substance abuse issue? How does the homelessness influence the mental health and substance abuse issues? How are these all influencing each other? And how do you propose to approach treatment in a way that is both amenable to the client and in their best interest? Once you've completed your assessment and your integrated summary, the person is given an appointment to start treatment. Hopefully, they are engaged at this point. They're wanting to participate. Send them reminders. People in crisis, people who are depressed, people who are having trouble coping with life aren't going to remember all of their doctor's appointments, etc. I don't remember all of my doctor's appointments, and I'm not in crisis. So it's just a matter of prompting them, because a lot of times it's not show up next Tuesday. It's show up 3 weeks from next Tuesday. Provide reinforcement, both for attendance and for making positive steps in the program. That can be in the form of rewards of some sort, tokens, reductions in treatment frequency or intensity, or the provision of food. Food tends to be a big one in community mental health agencies, not so much in some of the private facilities. But a lot of our clients, where I used to work, weren't getting their bellies filled. The only meal they got oftentimes was when they would come to treatment. So providing meals for them, and there are several federally funded programs for ensuring adequate health and nutrition that your agency can look into. Ensure flexible frequency and intensity of services. You don't want treatment to be part of the problem. So if the person, say, gets a job and they were coming to day treatment, hopefully you have a night treatment program they can come to. If the person has something else come up, try to be flexible with the frequency and intensity of services. There may be certain times where it's more appropriate for them to be in intensive mental health services and in maintenance substance abuse services, and vice versa. Reduce waiting times. After your assessment, that example I gave before, unfortunately, is all too true, that the first appointment is often 3 weeks from next Tuesday. That doesn't work. If I could wait till 3 weeks from next Tuesday, I probably wouldn't be in your office. So we need to actively and rapidly engage people. If you have outpatient outreach groups available, so they can come to group tomorrow. It can be just a basic, general, run-of-the-mill psychoed group, but there will be a clinician there that can put eyes on and can intervene in any crises that are coming up. It provides the person hope that treatment's not far away, that if they can go to these groups, they can start getting a handle on it, and then when a space opens up in more intensive treatment, they'll be able to get in. But it doesn't leave them out there floundering for 3 weeks. Co-occurring disorder-specific groups are also important. There are a lot of things that can be done in groups with people with straight substance abuse issues, but there are also a lot of issues that are very unique to people with co-occurring disorders, such as medication compliance. If you have certain groups specifically for co-occurring disorders, these people in group are coming from the same community, most likely, give or take, 20 miles, maybe 50. But they're also going to end up going to the same support groups on the outside. If they have groups where they can start to form alliances in a safe environment, they'll be more likely to engage in the peer support groups once they get out of treatment or during treatment, because they won't feel like they're walking into a room where they don't know anybody and they don't know what to expect. Case managers. If I could have a case manager, even just one for every 30 clients, I would be in seventh heaven. But the way that the Medicaid rules are written in our state, most of my clients didn't qualify. They weren't sick enough. So what do? Well, we'll talk about that later. You need to get outside the box. But case managers are extremely helpful at being your first line resource to identify when somebody's starting to decompensate. Strengths-based treatment planning in coordination with the client. Now, this is one of my longer ones, but it's important that it be strengths-based and done with the client. Don't just write the treatment plan and hand it to Jim Bob and say, sign this. They have absolutely no stake in completing that treatment plan unless somebody else is making them come to treatment. It's not theirs, it's yours. Help them write the treatment plan. This not only gets them invested in the outcome, but it also teaches them how to solve their own problems, how to break things down into sub-goals and move sequentially. Finally, provide peer mentors. When somebody comes into a group, pair them up, buddy them up with someone who's already been there for a while, who knows the ropes, who can show them where the bathroom is, where the cafeteria is, if you have a smoking facility, where they take their smoke breaks at. Somebody who can help them feel more at ease. That way treatment isn't scary. Again, we don't want treatment to be more the problem. There are various levels of service. Early intervention, outpatient, intensive outpatient, residential, or medically managed intensive treatment. So you go from early intervention, which is like group once a week, all the way to hospitalization. Depending on which form your agency uses, the ASAM or the locus, each one of these forms designates basically a checklist for scoring and helping identify where the best placement is for this client based on their environment, their readiness for change, any comorbid behavioral or medical disorders, etc. We're not going to go into how to use those things here since there's so much variability across agencies. My favorite, I feel it's the most comprehensive, but it's also the longest, is the locus. But in the facility I worked at, we used the ASAM because it was the shortest. You could still get compensation from Medicaid and our other providers if you had the ASAM in there. Just the same amount as you would if you had the locus. So cost benefit as far as time went, the ASAM won out. Then you've got to decide on the type of treatment to place this person in. Addiction only is fine for people who are truly straight up addiction only clients because they don't address mental health issues. Those are the exception, not the rule. The rule is dual diagnosis. So referring to a dual diagnosis capable or enhanced program is the next decision. Dual diagnosis capable programs are, just as it says, capable of handling DD clients, but they are not capable or not as capable of handling dual diagnosis clients that are highly symptomatic. They also address mental health and substance abuse, but don't have as many of the overlay services that you see in dual diagnosis enhanced programs. When you look at quadrants of care, this is another way of evaluating placement. Quadrant 1 means the mental health issue is low severity, the substance is low severity, and it can probably be treated in a primary care setting with medications and referrals. Quadrant 2 means there's a high severity of the mental health disorder. Substance abuse, not as big of a problem, sort of ancillary in the big picture. That can probably be treated in the mental health system. A lot of these people are self-medicating for their mental health disorder. Quadrant 3 is the low severity mental health disorder, high severity substance use, and they often need to be treated in the substance abuse system. And then finally, quadrant 4, high severity mental health, high severity substance abuse, probably need to be treated in an intensive medically managed system. Now, tip 42 talks about the comprehensive continuous integrated system of care model, the CCISC. This model is grounded in the following assumptions: that the 4-quadrant model is valid for service planning. So looking at those 4 quadrants we just talked about is a valid way for identifying where the person should be referred to. Individuals with co-occurring disorders benefit from continuous integrated treatment. Well, we already figured that out. And programs should provide integrated treatment for substance abuse and mental health, in which interventions are matched to the diagnosis, phase of recovery, stage of change, level of functioning, level of care, and the presence of external supports and/or contingencies. So let's go back through that. Interventions are matched to the diagnosis. Well, that makes sense. We'll move on. The phase of recovery. Where are they at in their recovery? Are they drunk? Are they in early recovery? Are they in late recovery, maintenance, or hopefully not relapse? And what is their stage of change? That means where's their motivation? Pre-contemplative. They don't have a problem. At least they're not willing to tell you they do. Contemplative. They're willing to admit that there might be a problem, but not willing to admit that they need help. Preparation is when they've admitted they need help, they admitted they have a problem, but they're not quite ready to take the next step and actually do anything about it. Action. Bet you can't guess what this one is. They're ready to get treatment. And maintenance. Another one, pretty easy. They've gone through treatment, they've developed a relapse prevention plan, and they're maintaining their sobriety. So by their diagnosis, where they are in the phase of recovery, where they are in their stage of change, their level of functioning, can they get by day to day, or do they need constant supervision? What level of care do they score out for? Outpatient, intensive outpatient, residential? And are there external supports or contingencies? External supports would be family, friends, social supports, a job that they've been at for 20 years that they like. Contingencies would be things like a case plan with the Department of Children and Families, or being in drug court or mental health court, in which there are rewards and punishments for their ability to stay clean and sober and medication compliant. Integrated interventions. Again, that integrated word comes up again. Address mental health and substance abuse simultaneously. They accept the fact that somebody's depressed and they're abusing substances, you have to address them both at the same time. When you're stressed out, you're going to want to use. So how do you deal with both of those things? Examples of integrated approaches include integrated screening and assessment. You don't have somebody go to a mental health person for a mental health screening and a substance abuse person for a substance abuse screening. The people who can do screening and assessment are trained in both mental health and substance abuse issues. Provide dual recovery and mutual self-help meetings and recovery groups in which both issues are addressed, mental health and substance abuse. And again, medication compliance and medication side effects. This is something that comes up repeatedly when working with people with co-occurring disorders. It's compliance and side effects and mixing medications with alcohol or illicit drugs. Motivational enhancement interventions, which apply to both substance abuse and mental health. And group interventions for persons with triple diagnoses of mental health, substance abuse, and something else. We put trauma here because that's one of the more common ones, but you can also have homelessness, criminality, any other major issue that's going to impact their ability to recover from the mental health and substance abuse. These all work together kind of like a little spider web. And provide combined psychopharmacological interventions. One of the things that used to frustrate me more than anything was when we would get a doc coming through the facility, and unfortunately we had our fair share, that would just be adamant that no one was going to get medication for depression or anxiety until they had 30 days clean in a residential facility. And that made it really hard to work with people in early recovery. Their fall was bad enough, but then add depression and anxiety on top of it, and they were pretty much incapacitated. So helping the people advocate for themselves and advocating with the physician to address both the mental health and substance abuse, as long as the person is in a safe environment, is extremely beneficial. Elements of successful programming. The no wrong door policy has 5 major implications for service planning. Assessment, referral, and treatment planning in all settings must be consistent with no wrong door. We talked about that earlier. It's not just in community mental health, but in the doctor's office, in the food stamp office, in the jail, in the hospital emergency room, whatever. Wherever people are being assessed, there needs to be a no wrong door policy. Creative outreach strategies may be needed to reach some people who are not really wanting to go to substance abuse treatment. Develop rapport and engage them in something. Health maintenance, education, community-related stuff. Once you can develop a relationship with this person, then they may be more willing to try treatment again. Programs and staff may need to change expectations and program requirements to engage reluctant and unmotivated clients. As I said earlier, many clients who have co-occurring disorders have been through the system at least once and failed. They feel beaten, they feel rejected, they have their self-esteem lowered, they don't feel like there's any hope. They may not know what the next step needs to be. So reaching out to these clients in a way that is meaningful to them and providing success, not that they go through the program for 30 days. Lower your expectations to something that they can do so they have the success. And that's good for you, it's good for them, everybody has a success. And treatment plans should be based on clients' needs and reflect changes over time. Please don't write a treatment plan for somebody with a co-occurring disorder or a substance abuse, well, any treatment plan, and not review it at least every 90 days. If your client hasn't shown some change by then, something's going wrong anyway. So you need to go back and reassess the treatment plan, identify what they've succeeded at, real good point there, tweak anything that may not be going so well, and make some new goals. And the overall community-based system of care needs to be seamless. Goes back to making those referrals. If you say, well, you need to go get a referral for food stamps and for low-cost housing and for child care, here's the number for information and referral, goodbye, have a good day, that's not going to work. If you can help the person, even if you can't do the ideal and help them sit there while they make the calls, if you can provide them with a contact name of someone who will answer the phone, return their calls, and help them into the program, you're going to be a lot better off. Appropriate levels of care. Basic care treats one disorder and refers for the others. This is like your substance abuse only treatment programs or your mental health only treatment programs. Intermediate focuses on one disorder and provides limited attention to the other. This is more like your dual diagnosed capable programs. Advanced is integrated to address the mental health and substance abuse issues pretty much equally, but fail to provide the wraparound services. And fully integrated programs address mental health, substance abuse, life skills, employment, housing, child care, help them navigate their way through the legal system if they need to, or at least connect them with someone who can. On-site psychiatric services are also crucial to provide a timely response when someone does start to decompensate, and it can be done via someone who's on staff or with an agreement with a local provider, such as your emergency room, your local mental health agency, somewhere where there is a psychiatrist that can be accessed relatively easily. Family education is another important component to treatment, but you need to be flexible in your definition of family. It's not necessarily mom, dad, sister, and brother. A family for a teenager who's been living on the streets is going to be very different than the family of a 45-year-old man who has a wife and 3 kids. Whoever is that person's core support system can be defined as their family for the purposes of recovery. Family education needs to educate about the disorder or disorders and their interactions. What is addiction? What is depression, anxiety, schizophrenia? Medications that people commonly take and their side effects. Relapse warning signs, and these are going to be individualized to the person. And relapse prevention strategies. A lot of times, significant others, the family support system, sees the relapse warning signs before the person realizes that they're there. So helping the family be aware and helping the family understand the relapse prevention strategies can help them intervene with the person and prevent a relapse from occurring. It educates them about how to model healthy coping skills. Chances are the people in that person's support system don't have healthy coping skills. It's very rare that we have someone with a substance abuse issue come from a perfectly healthy family. They like to make you think that, but it's rare. So if we teach them how to model healthy coping skills, we avoid pointing the finger at them and saying, you're causing part of the problem. we put it in perspective of their helping their friend or their loved one by showing how to cope in a healthy way. Eventually, there may be a time to address family issues that led to the addiction, but in early recovery, it's rarely the time. It needs to educate about triggers and how the family can help. For example, not keeping a fully stocked open bar in the house. Not having all your friends over for a football game with 15 six-packs of beer while you have a loved one in the house that's trying to not drink. And how they can help. I mean, not having it in the house is one. Not coming home with it on their breath is another. We're not necessarily saying they can't drink. It would be ideal, but a lot of people don't go along with that. What we are saying, however, is don't rub the person's nose in it. It's just going to serve as a trigger. As self-fulfilling prophecies. So often we have clients that graduate from treatment. They are doing wonderfully. And they leave and they go home, and all their family does is look for signs that they're screwing up. They fail to reinforce the positive steps, identify the good things. They just expect the worst and they look for the worst. And they end up creating a situation where the person feels helpless and it's like, well, if I'm going to be accused of it, I might as well go do it. Sometimes that doesn't happen, but many times the family system is organized around having an identified patient. And when the identified patient is gone, they have to find a different way, a different equilibrium. So the patient has to be able to maintain sobriety while the family changes and they recalibrate. Discharge planning begins at admission. Now, we've been saying this for years, but nobody really knows what it means. What it means is when you take somebody into the program, you know they're not staying there for a year, 2 years, 3 years, whatever. So your goal in treatment for whatever time you have them there is to help them figure out what they need to do, what skills they need to get in order to stay clean and sober when they get out of treatment. What do they need to have by the time they discharge? And this is going to form the foundation of your treatment planning. Hopefully they're not going to discharge from residential to once a week outpatient, or worse yet, just 12-step meetings and no treatment at all. Hopefully they will go from residential to IOP to outpatient to maintenance or relapse prevention or whatever your program calls it. Discharge planning also needs to ensure a continuity of care. So once the person is discharged, they don't have to go try to find a new psychiatrist who's going to keep up their meds. They don't have to go find a new therapist who's going to pick up where you left off. And if you do have to transfer the patient to a different therapist, make sure your notes are complete. Don't make them go through everything that they've done in the past 30, 60, 90 days and try to catch the person up. That's not only insensitive, but it also doesn't convey to the person that you really cared enough to try to set things up for them. Now, case management is frequently not available. Unfortunately, a lot of our clients don't have a GAF score low enough to require case management. That doesn't mean they don't need case management or wouldn't benefit from it. So how can you provide this service in a community-based system when insurance providers won't pay for it? Well, there's a few ways. You can have case management type groups. You can have just a general case management group or break it down into basically life skills groups. Financial planning and budgeting, job skills, job seeking skills, whatever. Medication compliance, that would also cover how to get your medications and pay for your medications. You can have a telemanager, one person who mans a phone line and basically serves as an information and referral person. Obviously, you can also use information and referral. Depends in your particular locale whether your INR people are helpful. In ours, they're extremely helpful, but I've heard in other places, clients might not be able to actually articulate what they need sufficiently to get the help that they need from the information and referral hotline. And volunteers and interns. Churches, many times, are just hit up all the time for volunteers. So they're not necessarily the best place to go. But sometimes there's a cohort of people within a church who have a soft spot for people with addictions or mental health issues. So don't just completely discount churches as being overwhelmed with requests already. The other place to look is at your community colleges and your colleges. Most places have colleges and universities within, 20 or 50 miles. Now, you might not be able to get an intern to come out every day, but you might be able to get them to come out once a week. And most people that are working towards a certification in substance abuse treatment have to have like 3,000 or 6,000 direct contact hours with substance abuse clients. Now, it doesn't matter whether those hours are paid or not. So if you can tap into the people in your community who are working towards substance abuse counselor certification, you will probably find a wealth of resources, a wealth of people who are available to help with case management. Yeah, they can't do counseling yet, but that's fine. You're not asking them to. They are probably more committed because that's where they want to go for a career. And they probably have a greater awareness of particular issues that are going on if they want to work in substance abuse counseling. So these are all places that you can tap, or populations that you can tap, in order to find volunteers and interns to help out. They don't necessarily have to go and do home visits for case management. They can have set office hours either at the facility. You might be able to work something out with the local library or a local community center. Whatever's more convenient for that person and convenient for your clients. And when we talk about continuing care, we want to help clients master community living, develop their vocational skills, achieve gainful employment, increase their understanding of their disorder as a disorder. It doesn't have to define them as being depressed. They can be John, not depressed John. They have to have an increased assumption of responsibility for themselves and for doing what needs to be done, not taking the easy way out and blaming their depression or their substance abuse or someone else. Not throwing blame, but taking the responsibility. And they need to consolidate their changes in their values and their identity. In treatment, most people go through this awakening process where they either rediscover who they once were before they started using, or they discover who they are because they started using when they were like 9 and never developed a concrete identity. They don't know what they like. They don't know what makes them happy. They don't know who they are or what they stand for. So during continuing care, while they have these ideas, they start consolidating them, acting on them, and acting them out. Key services will be life skills education, relapse prevention, 12-step or double trouble groups, case management, especially for housing, vocational training, and employment. Now, your life skills groups can cover a broad array of things, including fitness and nutrition and sleep. A lot of times I would put that all in one group that would be covered over several weeks. We talk about how to exercise, of course, but also the benefits of exercise, how it can reduce the need for certain medications, and also important considerations for exercise. Many of your psychotropics are going to be dose dependent, if you will, upon a person's level of hydration. So you want to make sure they're staying hydrated while they're exercising. Don't dwell on that. Make sure that they know it, but also emphasize all the positive aspects and the fact that fitness, exercise doesn't have to be running or necessarily even walking. It can be playing with their dog. It can be gardening. It can be any variety of things as long as their body is moving. At this point, we're not concerned about getting them working out in their target heart rate zone for 40 minutes 3 times a week. We want them to move. We want them to stretch. We want them to get fresh air. Nutrition. Focusing on what the food pyramid is. Focusing on the impact of sugars, especially refined sugars, on their blood sugar level and their mood. Caffeine. Again, focus on their blood sugar level and their mood. Help them see how all these things impact. Are we saying don't drink caffeine? Well, ideally, no. But in reality, most of our clients are going to drink caffeine. Okay, fine. Don't take away every vice they have, but help them learn how to use it responsibly. They need to learn that it has a 12-hour half-life, I believe. So if they want to sleep well, they shouldn't drink caffeine after about noon. Stress management. This is one of the biggest things. How do they cope with stress? The serenity prayer. Identifying things that they can change and things that they can't change, and how to let go of those things they can't change. What works for them for stress management? Is it cleaning? Is it writing? Is it painting? What is a good activity for them when they're stressed out? Probably not trying to focus on something that requires a lot of energy. If they can give themselves some downtime, some recovery time. Stress management also involves relying on social supports. So who can they call when they get stressed out? What can they do besides be alone, because it's a dangerous time? Health maintenance. How can they keep themselves from getting sick? How can they keep themselves from being in pain? What things do they need to consider to deal with any medical issues they currently have? Financial management and budgeting. How in the world do they pay their bills and get the debt collectors to stop calling? How can they open a bank account and save money when every time they've done it before, as soon as they got up to $500, they blow it on crack cocaine? There are a lot of things they can work out with their bank, where they have to have a cosigner, for example, to take out more than $50. There are a lot of different things, but if you help them link with a financial advisor, they will be better off. If you don't have anybody that's a financial advisor in your community, you can also usually hook them up with somebody at their bank. Job seeking and maintenance. Finding a job is hard enough, but then how do you keep it? Punctuality, dress code, responding to authority. All the things, think about all the things that cause a lot of our clients to get fired. Communication skills. Not only how to talk, but how to listen, and how to actually effectively communicate. How to say what you mean and open up to certain people. Now, there's also boundary issues with some clients, but a lot of our clients just keep everything all bottled up and it eats away at them inside. So we need to help them learn how to communicate their feelings and actually get in touch with them. Relationship skills. How to be in a healthy relationship. What a healthy relationship is. How to end a relationship. One of the things that comes out of a good treatment is when you discharge someone, there's a termination of sorts of a relationship. And this may be the first healthy relationship termination this person's ever experienced. So help them develop relationship skills. And for some of your clients, you'll need to have parenting skills groups. If they came from an addictive or an abusive family, they probably have lots of room to learn. Relapse prevention skills is another area that needs to be addressed in continuing care. Self-awareness and grounding. Hopefully in treatment they learned and they practiced regular self-awareness and grounding. When they woke up in the morning, they said, how do I feel? Emotionally, mentally, physically, spiritually, what are my goals for today? And in the evening, they did the same thing. They reviewed where they were at emotionally, mentally, physically, spiritually, whether they accomplished their goals for the day, how they felt about stuff. Not everybody likes to write this stuff down. I am the last person in the world who you'll ever catch journaling. It's just not my thing. I'll talk about it. I love to talk, but I don't like to write things down. So work with your clients. You can pair them up. You can have them call their sponsor each night, but they need to make sure that they're grounded periodically through the day in order to be aware when they have relapse warning signs. Self-care. Hungry, angry, lonely, and tired. They need adequate nutrition. Coping skills. Social support. And rest. Treatment and recovery is a full-time job, and it's exhausting. And most people don't have the luxury of just doing treatment and recovery for a year or more. So it's important that our clients realize that they will need rest. They will need relaxation and how to tune in and listen to their body. Yeah, if they're at work, they can't lay down and take a nap, but they can go to bed earlier that night. Fortify support systems. How to build on those support systems. Increase their breadth and their depth. And they also need to work on being aware of relapse warning signs. Keeping a list of what their relapse warning signs are and ways to deal with them. That way they can be empowered to nip it in the bud, as it were. Episodes of treatment, unfortunately, are time limited due to space, funding, or client motivation. Many places say you've got 28 days, you're out the door. Some places will grant limited extensions, and this is either due to space, needing to get more people into the beds, or due to funding, insurance won't pay anymore. Or in some cases, the client reaches a level where they feel, quote, better, and they need to go out and try it on their own again because they feel like they've got it licked. We all know that client who just, they're in there for 3 weeks and they're starting to come out of the fog and they know what the next right thing is to do and they're ready to go. Pretty much after that, you're not going to make much progress. So, okay, that episode of treatment is coming to a close. I always challenge my clients to prove me wrong. I love to not see them come back through detox. So if I think a client is discharging prematurely, I can't stop them. In our facility, it wasn't a lockdown. I would tell them my professional assessment. I would tell them my concerns. But I'm not going to hamper them from doing what they feel is what they need to do at the moment, as long as they have thought about it and it's not an impulsive decision like after a visitation, all of a sudden they need to discharge. So, in any event, if they come back through, their next treatment episode should build on prior progress. Keep good notes. Even if they don't come back to see you, the next therapist should already know what you tried, what worked, what the patient was working on, and where they can pick up. That will go a long way towards reducing the get up and go time. If the therapist can pick up the file and see where Jim Bob was at and what issues were present and pressing 6 months ago, then they can start from that point, assess where they're at now, and move on instead of starting from scratch. Now, there are a couple of outpatient treatment programs that are currently being used. Assertive community treatment and intensive case management are helpful for, and I don't like the word non-compliant, but non-compliant clients. And a lot of these clients are not willfully non-compliant. They just can't remember to take their medication, and maybe they can't get to treatment because they live somewhere that's not on the bus line. There's a lot of can'ts there, and sometimes it's hard to ferret out the can'ts from the won'ts. But assertive community treatment is helpful with this population. If they have a low readiness for change, now you remember, readiness for change is variable or is applied individually to each problem. They may be very ready to change their depression, but not quite so ready to change their substance abuse. So you need to look at the client as a whole, but also individual problems, and work with them actively on the ones that they're really ready to change, but don't forget about the ones that have kind of drifted off. And it's also useful for clients who need high supervision. Again, those clients with mental health issues and substance abuse issues who are going to require ongoing medication, who require high supervision to maintain medication compliance, etc. It's important in these programs to add substance abuse treatment components, such as substance abuse education, peer mutual self-help, and greater personal responsibility. This depends on the client, how much personal responsibility they can take, but it's important to encourage them to take as much responsibility for themselves and their treatment and their health as they can. Residential treatment for clients with co-occurring disorders comes in a couple of different styles too. One of the most common is therapeutic communities. The goal of the TC is to promote abstinence, decrease or eliminate antisocial behavior, and affect a global change in lifestyle. It views drug abuse as a disorder of the whole person, their attitudes, their values, their behaviors. But when you're working with a population that has co-occurring disorders, the TC needs to be modified a bit to have increased flexibility, decreased intensity, and greater individualization. TCs can get pretty in your face, and if you've ever visited one, you're familiar. They can be extremely confrontational, and this is in part due to the desire or the goal of eliminating antisocial behavior. Nevertheless, a lot of people with co-occurring mental health issues can't handle quite that much confrontation. So again, a little bit of decreased intensity, increased flexibility, and individualizing the treatment to greater fit the person. In a TC, in order to measure success, you want to look at whether a set number of program hours with a predetermined level of specific groups or activities is delivered. You don't want it to be willy-nilly, oh, I guess I'll do this group, or I'll do that group, or don't let the counselors decide what group they feel like doing on any given day, or if they feel like doing groups. There needs to be a certain number of hours of group that covers a certain topic or topics at a given level. It can be pre-contemplation or more treatment-oriented. And to ensure a therapeutic environment, you want to look and see, is the community being used as a healing agent? Do they reflect upon each other? Do they seek out peers for support? Is there trust in interpersonal relationships among people in the community? And do the clients perceive the TC as a place for recovery, or just as a place where they got to do their time until they can get out? There are several dual recovery 12-step fellowships out there. Double Trouble, Dual Disorders Anonymous, Dual Recoveries Anonymous, and Dual Diagnosis Anonymous. Encourage your clients to seek these out. The common features of these, as well as other 12-step fellowships, is a plan to achieve and maintain recovery and organize resources, literature describing the program, meetings chaired by members to provide support and acceptance, and plans for establishing an organizational structure to guide the growth of the membership. The Dual Diagnosis Recovery Network provides dual recovery and mutual self-help support information, education through community programs, in-service training, workshops, and conferences, advocacy and coalition building that engages caregivers, clients, and family members, and information dissemination through a quarterly journal and clearinghouse. Links to these particular resources can be found within this tip if you look up the full version. Specific populations. 70% of homeless people surveyed identified substance abuse as the primary reason for their homelessness. Homeless people with co-occurring disorders tend to have a variety of medical problems, including HIV, TB, and staph infections. They're frequently victims and participants in crime, and are disproportionately likely to use drugs and alcohol and to have some form of mental illness. Two different service models emerge as being effective with this population. Housing first, where housing is provided first and then the rest of the resources fall into place. Or housing contingent on treatment and work therapy, where housing is provided, day treatment, 5.5 hours a day, and work therapy. The criminal justice population requires staff that are trained and experienced in treating mental health and substance abuse disorders, both of them being primary. That means you don't treat one, then treat the other, or treat one more intensely than the other. They're treated in an integrated fashion. Treatment is comprehensive, flexible, and individualized, and the focus of the treatment is long-term. You don't just want to work with someone who was recently discharged from jail, assume you're going to see him for 4 weeks or 8 weeks, and be done. This is a long-term process that you want to step down the intensity of services over the course of a year or more. Additional considerations which I ran into when I was working in community mental health and working with this population was the criminal mindset. It's us, them. We are after them. We are in some way trying to make their lives miserable. We don't understand. And I'm the first to admit there are a lot of things I don't understand, but I am more than willing to try to understand. Look out for number one. Most of the clients who came through, they had to watch out for number one because there hadn't been somebody to look out for them. and social hierarchies. In jail and out of jail, within the social system that they run, there are social hierarchies, and there's fierce loyalty in many cases. Being aware of this and how hard it is to divest themselves is very important. Look at the motivation for their criminal behavior. Is that where all their friends are? Is that all they've ever known? Is that how they cope? What is it that motivates? What's the benefit to their criminal behavior? For some people, 3 hots in a cot, 4 hots in some places, in jail is more comforting to them than being out where they have to take responsibility for themselves. Self-esteem. No matter how big and bad and all of that they try to be, a lot of clients who are in the criminal justice system have very low self-esteem. They are extremely externally validated, and they measure their worth based upon what other people think about them and how much loyalty they inspire. This is a big thing because they are not capable of self-validating. Barriers. Housing. A lot of low-cost housing will not let people in who have criminal histories, especially drug-related offenses. Employment. A lot of people won't hire people with criminal histories, especially drug-related offenses. And social stigma. We tell them not to go back to their old friends. They need to change people, places, and things. But a lot of your people who don't have criminal justice backgrounds, a lot of people who don't have criminal histories, discriminate against people who do because they see them as being somehow deviant. So they're discriminated on 3 of the biggest fronts available. So how is it that we expect them to just walk out of jail and do the next right thing? We need to help them overcome these barriers. We need to advocate for them. And yes, there are some people who are in the criminal justice system who are antisocial or have other issues, and they may need to be there. But the vast majority have other stuff going on, and we can help and we can stop the revolving door. Enough of my soapbox. Women. Now, this was listed in the tip, so I felt compelled to put it in here. But I also feel compelled to mention that as we're learning through new research, the incidence of domestic violence with men being victims and sexual abuse with boys being victims is far higher than we ever had anticipated. Child care is another issue that some dads have to face. So these are special issues that need to be dealt with in maybe a same-sex group, as opposed to thinking of just dealing it with women only. You probably don't want to put males and females in a domestic violence group together, even if they were both victims, because there are going to be some transference issues. Nevertheless, again, don't forget, guys have issues too. So, enough of that soapbox. Domestic violence, abuse, pregnancy issues. Many psychotropics cannot be taken during pregnancy, so how do you deal with that? How do you stay clean and sober? What are the effects of alcohol and drugs on the fetus? How are hormones affecting the pregnant woman? And what is the postpartum outlook? Has this person had postpartum depression before? If they have a pre-existing mental health issue, there's a greater chance that they will develop postpartum depression, even if it's their first child. What can they do to prepare and prevent and basically set a safe stage for this child to be born into? Child care. While they're at work, while they're at treatment, child care is one of the #1 reasons you have treatment dropout. So if you can facilitate, again, through volunteers, interns, whatever, some sort of child care arrangement whereby if people don't have child care, they can bring their kids, so that's not an excuse for failing to show. You're going to be one step ahead. And child custody issues. Once a person admits themselves into treatment, then they potentially open themselves up to more scrutiny in child custody issues, which makes seeking treatment actually a more difficult choice for a lot of moms who have children. Once your agency decides that, yeah, we either are already serving clients with co-occurring disorders and we need to improve our services, or we want to start serving these clients, you need to assess your current community need. How many people are actually coming into treatment with co-occurring disorders? What services and networks already exist in the community? What unmet needs are there? And are there available services? Maybe there's unmet needs for respite care. That's a big one. And there's one church that provides it. I know in our area there's one church that provides it. But it's not well linked with the other places. So we need to bring them into the network. We need to ensure that this network, this safety net out there, is seamless and comprehensive. And then you're going to identify needs that are out there that just aren't being met right now. So it's going to take collaboration with community partners to figure out how to meet those needs. It can be done, it's just a little challenging. Then enhance the network communication and collaboration. Have one person in each agency that you can talk with, that you can communicate with, instead of trying to just reach whoever answers the phone. Increase provider knowledge in all agencies about mental health and substance abuse issues, available resources, how to make a referral, and to whom at each agency to make the referral. Again, you don't want them, a client or even a partner, to have to call another agency, get somebody on the line, and just hope that they know that you're a partner and what needs to be done. You want to make sure that this is a seamless, nice transition where everybody, the right hand knows what the left hand is doing, so to speak. In the mental health field, co-occurring disorders, substance abuse or otherwise, burnout happens. Some ways that you can prevent it is to work in teams. Don't saddle the responsibility for everything on your own shoulders. Yes, there may not be case managers available, but you may not be able to provide case management and counseling and this and that to the other person. If you're working with clients with co-occurring disorders, try to have smaller caseloads. And smaller depends on your agency and the intensity of care, outpatient versus residential. Ensure family health. You're not going to be any good to anybody if your family's falling apart. So make sure to separate work from home and take time for your family. Integrate time for team decompression. And this is a time away from clients, not at 3:30 in the afternoon when you're sitting in the office mate's office, talking trash. Hopefully you don't do that anyway, but it happens. A time where the team can get together and decompress about their frustrations with what's going on, with providers, with clients, with situations, whatever, in an appropriate way, but in a safe environment with a supervisor or someone who can help hear, listen, and or advocate, make changes where changes are appropriate. Ensure adequate consultation resources are available. It makes life a whole lot less stressful if you always have somebody you know you can call and say, is this the right decision? A lot of things come up. You're dealing with people's lives. Involuntary commitment, doing well-being checks and breaching confidentiality. Preparing for a family session, maybe it's outside of your comfort zone, whatever. But if you've got plenty of consultation resources, then you're not left feeling like you're a fish out of water flopping around. And minimize turnover. This is sort of if you avoid burnout, you minimize turnover, and if you minimize turnover, you avoid burnout. When a new person comes into the agency, or an old person leaves, the clients tend to act out more because their homeostasis is out of whack. They like to know what to expect, and there's a new person in there. So it exacerbates a lot of clients. It also exacerbates the team. It upsets the apple cart, so to speak, because you have a new person in there and you have to go through that forming and norming that goes on in groups in order to figure out that person's style and how they'll fit in and everything else, which is exhausting. When you have a stable group, even if not everybody in that group is your favorite, if it's stable, you know what to expect and you can work pretty consistently. So try to minimize turnover. Training. You need to have training on differing perspectives regarding the characteristics of the people with co-occurring disorders. The nature of addiction, the nature of psychiatric disability. A lot of people who are working in community mental health are trained in mental health, go figure. Unfortunately, they're very poorly trained by their college programs, by their preparation programs for dealing with substance abuse. Likewise, many people with substance abuse certifications don't feel comfortable making mental health diagnoses, and in some states, it's not even legal for them to make mental health diagnoses. But they don't feel comfortable dealing with mental health issues either. And whether you like it or not, if you're dealing with persons with co-occurring disorders, you're going to have to deal with both the substance abuse and the mental health. You may be operating off of another clinician's treatment plan for the mental health part or the substance abuse part, but you need to make sure your treatment plans don't contradict one another and they work towards the same end. You need to look at the interactive effects of both mental health and substance abuse on the person and the outcomes. We know that there's a poorer outcome for people with co-occurring disorders. But I have to wonder whether that's because up until recently, we've been treating them in unidimensional treatment programs. So what happens if we start treating them as a whole person? Now there's a concept. In summary, co-occurring disorders are the rule, not the exception. Mental health and substance abuse need to be treated concurrently for best outcomes. And funding is limited, so agencies need to cooperate, collaborate, and get outside of the box.